All right, this is part 2.
I'd like to turn now just to the matter of survival from out-of-hospital cardiac arrest. I think it's extremely noteworthy that survival rates have doubled over the past 10, 15 years. This has happened in Seattle, and I'm sure it's happened in many other cities as well. And one of the critical things is say, well, how did this come about? Well, we can look at some things that, well, yeah, we're using new drugs, or we got some better devices. The answer is no. We don't have better drugs. We don't have better devices. A host of randomized trials have been conducted over the past 20 years, and virtually none of them has shown anything of particular use for the management of patients resuscitated from cardiac arrest. So what is responsible for this thing? I think it's very simple, that we do better CPR. We do different CPR to a certain extent, and we manage defibrillation, interposing it more properly with the CPR, with chest compressions. I think we owe a lot to our colleagues in Arizona for getting us on the right track in terms of utilizing uninterrupted CPR. It does, in fact, make a difference. For many reasons, you might say, well, this survival thing, maybe it's due to something else. Maybe the betterment is related to hospital therapy or hypothermia. And I don't think so. Maybe a little bit, but got to remember that with this improved survival rate, we've also seen betterment of return of spontaneous circulation and higher rates for admission to the hospital. So I think clearly this is something that's happened in the pre-hospital scene, and things have markedly improved. Now, I'd just like to turn for a little bit of day-to-day doings and talk about ventricular fibrillation survival rates. For many years, we've considered this to be the sole outcome measurement of how well we as an EMS system are doing. The rate of survival from out-of-hospital VF, particularly witness VF, is a very, very strong predictor, but it's the only outcome measurement we have for EMS, that we have a lot of process measurements we make, but the survival from out-of-hospital cardiac arrest is the only outcome measurement we have. And it's a simple measurement to take, you'd think, but sometimes it gets askew. And it is important to remember that the biases are built into it. Cases can be missed. You can count cases that perhaps shouldn't be considered as treated by EMS. So I believe that the guidelines for determining the survival rates should be made clear, and we make every effort to count all the cases resuscitated and failed. So there's only one other thing I'm just going to leave you with, and that is the notion that we are missing a big opportunity to improve outcomes, I believe. And that is the use of voice recordings during cardiac arrest. A lot of people don't like to do this because they fear, particularly amongst the medics, that they fear there's going to be recrimination or a big brother is watching you or something. But we've been doing this for 30 years, and we've never had any personnel issues at all. And we think it's one of the more valuable ways of improving the way we treat our patients. So, finally, ladies and gentlemen, I would again like to say thank you. This is indeed a wonderful honor. I feel privileged to have been, at least been here in spirit with you, and thank you very much. Goodbye.